I'm Havish Srinath. I'm one of the new general colorectal surgeons, literally started 6 weeks ago. So I'm replacing Stephen White, who finished when I was his fellow 2 years ago. And then I disappeared to WA for a year, and I've come back and joined Ross and Isabella at Coast Colorectal. So yeah, that's me. This is sort of my background, and thought I'd just quickly introduce. I grew up in Sydney. I did actuarial studies, thought I'd always want to be a mathematician, and then decided I wanted to do medicine. I came to Queensland, did UQ, and then came back to Tweed. Junior doctor, they got me into surgical training there, went back to Queensland, Johnny Cash reference there, because I've been everywhere, man, and then CSS as colorectal. So this is where I came back to Tweed, Flynn, when Stephen retired. And then I lived under the dictatorship of Mark McGowan for a year, and then decided to come back like Marty McFly, young and a bit silly. Anyway, so my talk is actually a bit different, because usually whenever a colorectal surgeon talks to you, it's always about bums and bleeding and hemorrhoids and fissures. Super happy to answer those questions, but I thought I'd talk about something a bit different, something that we're doing where patients might come to you and you go, they're doing what now? And this is part of that. So the preamble is, of course, colorectal cancer in Australia. You guys know this better than I do. Third most common cancer, excluding skin cancer. Second most common cause of mortality as well. And I'm sure you've got a full thing about screening with the aim to reduce morbidity and mortality. However, this is the problem. 75% of these cancers are still diagnosed when they present to the GP, all right? Or symptomatically, sometimes the ED as well. But this is what's concerning about colorectal cancer. We hope to decrease this number, and the majority is still via GPs. The symptomatic patient, well, what's the evidence behind it? Which symptoms, what should worry you for colon cancer? Anemia, still is anemia. And the thing is, you guys usually screen the patients, because if you have a patient younger than 40, female, menorrhagia, they're less likely to be the one with the cancer. But someone who's never had bleeding, who's now 70, male, obese, you're going to go, you got something brewing, and you're going to send a script. So when you guys actually screen them in your referred populations, 10 to 12% will actually have a lesion that's worth doing something about, polyps or cancers. Of course, rectal bleeding, changes in bowel habits, all concerning features. All of them increase with age, so those risk factors are the significant ones. Median age for colorectal cancer is 59, median age for polyps is 50. So that's why we think screening should start at 50. We could again talk about the ages and why that should change, or NHMRC recommendations and the funding, cost benefit and all of that. However, broad strokes, and I'm kind of sticking to this alone, these are the key symptoms to worry about. Of course, I'm a colorectal surgeon, and I've kept all my jokes above board today. However, still got to put this in there. This is kind of where we've been moving the past couple of years, unfortunately. I saw this, and this shocked me. Not the Ukraine war, I mean, that shocks me too. However, thousands of people having to wait with their cancers, delayed diagnoses, what's going on. Now, I don't know if that's flawed data. I have no idea if it's because of appointments, whether it's all telehealth, we're not examining patients, we're not able to do that, they're not able to come in. Is it the operations? Is it the fact that they're not getting scopes? Is it the fact that they're not getting the resections? It's flawed data because it just says delay. Certainly, looking at the Cancer Australia data in 2020, we've noticed a global, a drop in expected versus actual services for cancer procedures. Again, they didn't go into details about it. And then the bubble that I lived in, you can see even they were affected to some degree. That could be the fact that they're struggling and the healthcare system needs a bit more work. However, certainly in New South Wales and Victoria, you look at those numbers and you go, whoa, that is scary. And someone next door was telling me they had a patient who waited 10 months on Cat 1 in Queensland until they got their scope for cancer. And that, again, is scary. And I have no idea what's going to happen over this year as we keep resuming what we're doing, which is elective surgery and scopes and procedures. What is, however, the allowable time? So this is something that probably crosses your mind. What's an acceptable time when a patient walks in and diagnosed with cancer or you suspect it? 120 days, that's actually the time. And if you think about it, that's very reasonable in the pre-COVID era. They've seen you, you've gone, okay, you need something, you send them for a Cat 1 referral, triaged, Cat 1 usually seen within 3 to 4 weeks. We go, yep, sounds important, triage again, have a scope done, yep, you've got cancer, triage again for Cat 1 resection. If you add that up, it ends up being about that amount of time. That's the accepted diagnostic interval, because colorectal cancer on average is a slow-growing cancer. But we do know from other countries that you have poorer outcomes when it's longer than that time. okay, especially after GP presentation, to diagnosis, which is time to scope, not necessarily treatment even. Can we diagnose sooner? Yes. More importantly, can we prevent it? That would be even better. This is something that I came up with when I was studying for my exams. Soda pop. So if you take away one thing, soda pop. We don't like soda. Smoking, obesity, diet, and alcohol. They are the preventable risk factors. You can't prevent IBD. You can't prevent hereditary things. You can look at chemoprevention for one of those. We'll talk about that. However, soda pop, really, this is the focus. And this is the thing you guys would be talking to patients about day in, day out for all sorts of other issues too. Cardiac disease, of course. Physical activity is protective for colorectal cancer. And we still recommend calcium and fiber. The evidence is probably a bit weak for those, but the harm from fiber is almost negligible for most people, so soluble fiber are still recommended. Chemoprevention. If anyone asks you about this, well, aspirin. So even though the recommended guidelines from age 50 says that, the evidence is actually a bit skewed. The evidence is very good based on this study called the CAP2 trial for Lynch patients, high-risk patients who get aspirin. 10 years later, they may have a small benefit in preventing cancer. Not sure if this completely applies to the general population. So in the high-risk groups, there may be a role, but certainly Lynch syndrome, there is very good evidence for it, and they're the ones we use for it. And again, that came from when I went to WA. I worked in Fiona Stanley, so quaternary centre, where you see all the familial cancers. It's all the same families, and so they have good data, and we could actually institute that. It's not really that applicable everywhere else. And again, these are all the other medications that are commonly touted. Again, the evidence isn't there. So NSAID Sulindac is very good in FAP patients to prevent polyposis, but again, we don't know if that prevents cancer. Statins, metformin, bisphosphonates are some weak studies, but not very good evidence for it. When I think about colon cancer, I go, all right, have we got a diagnosis, scope and biopsy? Have we got HB and iron studies, because that affects their perioperative outcomes? And have we got staging, CT, chest, abdomen, pelvis? We will order PETs, we will order MRIs for rectal cancers, but this is really the basis of what I do. Because what can I do early before we deal with the cancer? Can I address the anemia? So having blood transfusions at the time, either before, time of the operation or right after it, in the perioperative period, increases the risk of local recurrence and mortality. Flawed data though, because I don't know if it's because the surgery was very hard and they bled to death on the table. So this is one of the things we try to avoid, and so what we try to do is give them iron supplementation preoperatively. Okay, and so this is where we give iron infusions if we can. Again, erythropoietic agents do have this increased thrombosis risk, so we, again, leaning away from that as well. We like to optimize the nutrition. So as part of our ERAS protocol for our cancers, we put them on Sustagen, Dex drinks. We minimize fasting time. We get them eating the next day. Try to minimize the burden of surgery. And of course, minimally invasive surgery for short-term outcomes are good. Long-term makes no difference. If they needed a cut, they needed a cut. Colon versus rectal cancer though. So with the rectum, it's a fixed area. So there is something else we can use, which is radiation. So normally with colon cancer, you can't use radiation for the most part, very few exceptions. But for rectal cancer, it is part of our treatment armamentarium, and we discuss this about whether we do it or not. So first we get an MRI, which is the only additional staging thing that we do. An MRI tells us the local T staging, and it determines whether we do it or not. And this is a simple way I think about it. So if anyone asks you or wondering about it, I like to think about it in the good, bad, and the ugly way. So if it's good, in other words, it's not locally advanced, it's not metastatic, surgery is probably going to be offered to them. And of course, the patient's well enough to have the surgery. If it's bad, in other words, it's metastatic disease, usually it's systemic therapy first. And if it's ugly, locally advanced, but not metastatic, chemoradiation works very well to attack the rectal cancer locally. Sometimes you defunction first so that they don't obstruct, but again, the main treatment is going to be the chemoradiation. But what does it actually add? The chemoradiation only improves loco-regional control and decreases local recurrence down the track. At the time of the surgery, it may shrink the tumor, as we like to think of it. It may make it a bit easier, but for the most part, it's all to do with local recurrence. And then you've got to still think about the postoperative functional issues, not on the operation, but also the radiation. Again, I'm very interested in bowel function and LARS, and we're going to touch upon that because that's what's going to affect you. Once I've done my bit, 5 years later, I say, see you later. They're going to come see you guys. 10 years down the track, they're going to have issues. And really, is there something we can do about it? So we're going to talk about the low anterior resection syndrome. Of course, sexual dysfunction, urinary function, I'm going to send to someone like Jürgen. That's where I'll think about that. And then I always worry about delayed strictures, recurrence, metachronous lesions, and things like that. However, first things first, the rectum. How does it actually work? Everyone goes, it's the reservoir, hold still. probably not completely accurate. So the rectum is a short-term reservoir. Most of your stool is actually stored in your sigmoid and above. When it empties from the sigmoid into your rectum, that's when you get the signals that actually I need to go and poo. In other words, your rectum is empty most of the time when you sit there. So if I remove the rectum, the patient loses that. And there's a little bit more, something called a rectosigmoid break. The rectum tells the sigmoid, hold on, hold on, hold on. Okay, I'm ready for poo. When you either have what's called a gastrocolic reflex or you get a mass migratory movement, that's when it empties into the rectum. These are all the things that I can mess up with an operation. This is with a good operation. So not only do I remove a rectum, the organ, I affect the anal sphincter function with the fact that we use a gun or a staple to make the anastomosis. The fact that the nerve supply gets disrupted when we take the lymph nodes for oncological reasons. The fact that I give a stoma to a lot of these to prevent a leak, 15% chance of a leak, but then stoma, which can affect the bowel downstream because it doesn't work. And these are all the things that I could cause to the patient. So this lady then came up with this option. So should we leave the rectum alone? Should we not operate on it? So Habagama, Brazilian surgeon, observed, because for rectal cancers, especially those ugly ones, we were using chemoradiation, shrinking it. And about 20-30% of the time, when they took the cancer or the colon and rectum out, pathologists said there's no cancer left. So in other words, like, wait, hang on, they've had fantastic response, so good response. And again, the mentality was, let's high five. Yes, they've had a big operation, but there's no cancer left. It's all cured. But the problem is that's a lot of morbidity that we could potentially avoid. And then TNT's the other new thing, which is where we can use radiation and chemotherapy first to really aggressively attack the tumor before surgery and before removing it. Again, whether chemo first or radiation first, 28% of the time in those two studies have shown that it can have complete response. The problem is who gets this, how do we select these patients, and what happens if it comes back? The salvage rate's only 85%, okay? Only 85% can be salvaged. There's a huge database of patients. So again, this is across the world and there's something to know about. And I certainly do talk to patients about it, especially patients that don't want surgery. And they come to me and go, are there any other options? This is an option. It may work, especially if you have a fantastic response. But there are some caveats. They need intensive surveillance. They need to live somewhere they can come in easily. 3 to 4 monthly flexible sigmoidoscopies, EU waste to check if there's any recurrence or regrowth, as we call it. They need MRIs. They're non-rebatable. That's expensive as well. They may need CTs and PET scans regularly. Biopsies are useless because the mucosa may look good, but cancer cells could be underneath it, underneath the mucosa after radiation. So these are all the flaws, and unfortunately it's not foolproof. So these are the risks though. 10% in this database proceeded to have metastatic disease. They could have been cured at the time. That's what we think. We don't know. But 10% of them progressed, and you're like, oh, that's tough. You know, they went from potentially curative to incurable disease. Local regrowth is estimated to be 25%, and only 85% of that can be salvaged. In other words, another 4% almost progressed that's no longer curative. Concerning. What are we doing though? Well, at this point in time, we're not yet jumping on that bandwagon. We certainly discuss it with our patients. We tell them that yes, it is done. A lot of places around the country, if you've had complete response, if you go into full intensive surveillance, we can watch you and we can wait and we can see what happens. Because the other problem is, how long do we watch for? Some studies are suggesting we need to watch for 7 to 10 years now, not just 5 years that we've arbitrarily picked. So 1 to 2, straight to surgery. 3, chemoradiation. 4, usually systemic control. But if it's oligometastatic, which means if it's only small number of mets, small volume mets to the liver or lung, we can still offer surgery to those patients. And the biggest question we have is, are we trading mortality to avoid morbidity? And that's the tough one. And then we get to my bit, which is the functional issues. All right. So the radiation effects, of course, can cause that. And on top of that, a surgery in the pelvis can cause that. So LARS is called low anterior resection syndrome. And interestingly, if you took population survey, 10% of the population will have it, because you'll see what the criteria is for someone to have LARS. And in this, we think 41% of patients will get major LARS after an anterior resection. What is LARS? Well, you need to have one of these symptoms and one of these consequences to qualify after an anterior resection as having low anterior resection syndrome. And you can see that that's actually pretty much a lot of people I do bowel surgery on. All right, and that's quite concerning. Certainly in rectal cancers, this is one of the things that really affects a patient years down the track. So, what can we do about it? So non-operative management of LARS before anything else is we anticipate, we educate them. So LARS is now in this group which is similar to fecal incontinence patients. And sometimes when they've had that, that certainly is going to contribute to it. And whether it's urge incontinence, whether it's passive just leakage, they're just getting staining, can we do something about these symptoms? So we obviously talk to them about it preoperatively, and we talk about the radiation, the surgical recon, but we try to minimize stoma or try to close it early. That seems to help. Try to leave as much rectum as we can, but it also depends on the pathology. Dietary modification, and again, you guys will probably notice this. Patients will change their own diet. Okay, they usually will have already come to me and gone, I've changed my diet, I've done this. Most of them try high fiber, most of them have gone low fat, get rid of alcohol. Some of them will say, cold beverage, spicy food, stir it up. So they will do this themselves. Insoluble fiber will usually worsen those symptoms. Soluble fiber seems to be preferred and can decrease clustering. So clustering is where they don't empty properly. So we use a bulk-forming laxative to bring it all together. Because what's happening is they're just not emptying it completely. They're getting incomplete emptying because their neorectum with colon is not working or communicating with the anus properly. Again, this is based on clinical expertise. There's actually no evidence to say the fiber really helps, but in some patients it may. Same with probiotics. There's no real evidence, but I say if it doesn't do you harm, possibly worth trying as well and see if it helps. Medications. So, of course, with loose bowels, we can use loperamide. Okay? Yes, it risks constipation. Topical ointments to protect the skin can be used as well. Interestingly, go the other way. You can try an enema to get them to empty completely, because it could be the fact that they're just not emptying fully, and so an enema will just help empty it all out, decrease the number of times they need to keep rushing back and forth to the toilet, and the preoccupation with that. I'm not going to really jump into the weak evidence behind remocitron and cholestyramine, but again, some other things that we have tried for these patients with LARS symptoms. Pelvic floor rehab. So we always talk about this in incontinence patients, fecal incontinence patients. The evidence actually isn't that strongly supportive, and yet we do it. We recommend everyone to go get it because it's a safe intervention, and a lot of patients, even if they have any procedures done, they need to retrain on how to toilet. And that's the part of where we get specific pelvic floor physios to do that. Biofeedback can sometimes help them, but certainly this is one of those areas which evidence is not there, but we still kind of tout it and recommend it quite strongly. I don't know if anyone's come across this one, transanal irrigation. So this, I came across this when I worked at the PA in the spinal injuries unit as colorectal consults. And it was pretty much to help these patients empty out their bowel, their neurogenic bowels. And it's literally a tube up their bottom end, balloon up, irrigate for about 30 minutes, maybe up to an hour, deflate, pull it all out, and then evacuate into the toilet, just to empty out.
Pay a lot of money for that.
Yes.
A lot of money.
Oh, yes. So, good evidence for this. Not so good evidence for that, but people like to try things, so.
I love it.
Yep. Exactly right. Exactly right.
It's full of toxins and all.
Yeah, and someone mentioned Gwyneth Paltrow across there, room next door, so I said, yep, to each their own. Not something I would do, but to each their own. Yeah, exactly. I think they call it water enemas or something like that, don't they? Yeah. Yep. Coffee enemas, yeah, yep, absolutely. And then, of course, invasive. Again, one of the things we stole from the urologist. So the urologists were using sacral nerve stimulators for urinary incontinence. No one can tell you how it actually works. I still don't know how it works. So we think, again, the way where we place it is the S3 nerve root foramina, a little lead into their battery pack. So we do a trial phase with a temporary lead, and we do that for 2 weeks to see if the patients get any improvement in symptoms. For fecal incontinence, where they don't have a sphincter defect, where we think it's either neurologically mediated or perhaps pelvic floor mediated or with the communication, actually has phenomenal results. Again, patient selection bias, I admit, but actually can help a lot of patients with fecal incontinence. Then we found in LARS patients, again, we can't explain why, but it seems to work. So someone brave enough or crazy enough or desperate enough tried it. And then we've extrapolated from that, we've done further studies, and we've gone, actually, for some bizarre reason, it's working. And this comes down to the autonomic innovation, whether we're neuromodulating, we're retraining, or is it actually the placebo effect of it? Don't know yet. But the most important thing I tell patients is this won't give you complete control back. This won't let you do everything, because that's what patients have lost. They've lost control of their lives, and they just want that back. what this can actually help is about 50 to 60% improvement in symptoms. And that's what we consider a success. So if they're not rushing off to the toilet, having to worry about pads all the time, having to stress about where they are and when they can go out with their friends or what clothes they can wear, that to us is a success when we're looking at fecal incontinence. So this is certainly a very, very useful avenue in select patients. There is one caveat to that, which is it is not publicly funded in Queensland and New South Wales. So in Queensland, in PA Hospital, again, we have to go through a few hoops and loops to finally get it put in, and we're only allowed a select number of cases in a given year. So very hard to get it in a big hospital like the PA. Trying to get it somewhere where I work, like Tweed, again, we've gone through the cost analysis and we'll put it through, because these implants ends up costing about 10 grand. It's a small battery, but only Medtronic make it. So it costs about 10 grand or so. The procedure takes 15 minutes to do, and it can change a life so significantly. So privately, with John Flynn, we've been doing them, and we do them. But unfortunately, because of that, public patients can't. And so for them, we use a lot of the other steps that we can and really push and hope we can get good results. Because what we really want to avoid is this, a stoma. Spinal patients in that unit, it made sense a lot of the time when they came going, what can you do? Can you give me a stoma? I'm sick of this. Look at this. Like, it's horrible. I can't clean myself. I don't feel it. My nursing cares aren't good enough. If you give me something, I get control back. And it's about giving them control over their own bowel motions. So in those patients, it was like, yeah, absolutely. To you, this will be like a godsend, a miracle. But for our anterior resection patients, this is what we were trying to avoid in the first place. This is what we did, a reconstruction down the bottom end, not give them an APR, which is, end stoma. But very rarely they do come back and go, I am absolutely miserable, I've tried everything, nothing works, and we end up having to give them a stoma. Kind of defeated the purpose of trying to join them in the first place. And again, we try, really try hard to avoid this and severe quality of life issues, as I put it. So that was the plan. Something new, something a bit different, hopefully something you haven't come across. Again, very happy with bums, very happy with hemorrhoids, fishes. I summarised colorectal cancer is important. We talk about screening. Soda pop. If you take away soda pop, I'll be so happy with that. And of course, I will discuss wait and watch with our patients, because they want to know that there is something like this. But I do put a lot of caveats and restrictions, and I tell them this is how we're doing it in Australia, and what standard of care is still considered. However, if someone is older, you're more likely to go, it'd be great if you got full response. You kind of pray for them to get full response so you don't put them through a major operation if they're comorbid. Younger patients, we hit them with everything, what we call TNT. We usually hit them with chemo, radiation, and everything to decrease the tumor bulk, because we've noticed that younger you are, the more likely you're going to have an aggressive tumor biology. Whereas older seems to be a bit more, somnolent even. But again, we don't understand the tumor biology completely. And again, there's left-sided versus right-sided cancers. And this is all, of course, left-sided and pelvic cancers. And the last thing is, of course, with fecal incontinence, there are options. There are things that we can discuss. There are things we can try for these patients. And I still don't get how SNS works. Of course, like I said, got to put some clean jokes in there every now and then. But what do we do at Coast Colorectal? So like I said, I've joined Ross and Isabella. So we do minimally invasive robotic stuff. I do gen surg and colorectal. And the only thing that I can offer over those two is I've got a short waiting list to see in clinic, of course, because I've literally started 6 weeks ago. And I work at public in Tweed, private at Flynn. Again, same thing, minimal invasive, and the pelvic floor work is the other thing. So Ross set up the lab 3 years ago, but I feel like a lot of people don't know about it. And I was like, I'm going to use this opportunity, because I'm going to go around and introduce myself, to tell people that Ross does this lab, and I'm also joining him, where we actually assess. So we do an ultrasound, sphincter complex. This is all awake, as bizarre as it is. We'll look at balloon, test rectal compliance, nerve conduction studies as well, all done about a course of 30 minutes. And then we will also recommend whether they need to see physio, whether they can have an SNS, it'll have benefits or whatever. So this is part of what we're also doing on top of that. And I personally love teaching. I did a master's in medical education just because I was bored, and I've also signed up with Bond Uni to do some of that stuff as well. So very happy for education discussions, journal clubs, things like that. So that's me.
Thank you very much.
My pleasure. Any questions?
your pelvic floor incontinence group therapy, would you be interested in those old patients?
Yep, absolutely. A lot of those old patients may still have some benefits depending on what it is, okay? So this is again something we talked about next door too, but sometimes it's not even the operative intervention, it's the fact that we sit down, we have a chat with them, and we explain to them these are all the things. And I'll be honest with you, sometimes it's just the longer consultation that we take to have a chat with them and explain the physics and the mechanics of what's happened. A lot of these patients, at least from what our experience has been, is premenopausally, sometimes they have obstructive trauma or anything like that. A lot of them tend to only get symptoms 30 years down the track, post-menopause. And that's when they start having these issues and then come to see us. And so a lot of the time counselling and doing those non-operative management can help significantly. And then, of course, we talk about it like transanal irrigation. That's something that most people haven't tried. And it sounds bizarre to most patients, but certainly something that I do discuss with them first. And then it depends on where the problem is. Because if they've got incontinence because of slight mucosal prolapse, like a Delorme's procedure, something that can be done with just a spinal anaesthetic without general, so it can be safe in older comorbid patients. And again, this is one of my little things, working in Tweed, and 2 years ago when I was a fellow, I actually did a research project looking at robotic surgery in old people over the age of 80. And a lot of places in Australia, including WA, puts a restriction on people because of age, but you've got to look at our population, and our population are sometimes very well 80s and 90s. And so I don't necessarily discount them just on that alone, but I appreciate if they're comorbid, there are less things we can do. However, there are still some things that we can do. But yeah. Anything else? Again, super happy for anything, even bum-related, diverticular related. Very happy to answer any questions that you guys had.
So when would you say surgery is needed for diverticulitis?
Yeah, quality of life symptoms. That's actually the biggest thing. So used to be old adage, 2 strikes and you're out. That's what a lot of surgeons used to offer. We don't do that anymore. Or even if they've had a complicated diverticulitis like a perforation and abscess, if it settles down, we don't necessarily offer it. If we can't get a scope through it, we'll probably offer it because it's strictured. If it's causing a fistula, we'll offer it. And then for recurrent grumbling diverticulitis, in essence, the patient comes to us or comes to you and goes, I'm miserable, I'm in hospital every second week, I'm needing antibiotics. Yeah, I'm over it, exactly. And they usually come to you going, my quality of life is so poor because I can't work, I can't function. Is there something to do? That's when we think about offering it. But you're very right, because that's a long consultation, because I have to stress to them that I may not make things better. But the thing with diverticulitis is if we've captured it on CT, and that's the one thing, you have to have captured it on CT, have to have seen inflammation in that bit of colon, correlate with the symptoms, and if so, removing that segment of bowel actually has about a 90% success rate, probability of 10% chance you can get recurrent diverticulitis in the remaining bowel. Yeah, so they're the stats, and so that's what I discuss with them, and I go, you are having bowel surgery, there is a risk of leak, about 2 to 4%, there is a risk of me injuring something else, but if you're that miserable and you wish to go ahead, then we can do that. Yeah. Yeah, certainly we don't do the 2 strikes and you're out. Some patients usually manage if it's just one episode every couple of years. They're like, nah, I'll just pop some antibiotics, I'm fine, leave me alone. Yep. Well and truly, I'll leave them alone. Cool. All right. Anything else? No? Awesome. Thank you.